apologize. Welcome to Friday Focus, September 30th, 2016. September went by pretty quickly. It's almost October. I think you can tell when you go to the stores and they're putting out, Halloween stuff. It's kind of sad. Christmas is coming. So we're going to talk about a few things at Allure that we're going to maybe kind of really focus in on. I was just talking with the accounting department today. We're talking about some things that maybe they thought we could offer patients that we really don't offer right now. And it's kind of like we can't be everything to everyone. I mean, that's just a reality. There's certain things we can't do. We can't be, like the bargain shopping place. Obviously, our physical space is too expensive. We do more high quality things. And we can't really offer everything to everybody. But the things that we do offer and we're experts at, we can offer to everybody. Okay, so that's what I want to kind of hone in on. So we can't be everything to everyone. But the things that we do offer, we have a captive audience, which is our patients. We should offer it to everybody, especially some things that have profound effects on their quality of life or their overall health. So I'm going to talk about 4 things that we're going to get back in the habit of screening for. So let's take the example of dermatology. And I know not all the offices can do dermatology screenings right now. We're going to have fixed that in the next few months. We're working on that currently. But the dermatology, particularly at Shelby location, we're going to get back in the habit of offering patients skin cancer screening. Now the reality is that if there's not enough dermatologists in the country to screen everybody every year for skin cancer, and that might not be cost effective, but I'm going to work with the dermatology PAs to teach our staff some fundamentals about recognizing abnormal lesions on skin, so that way to be identified, you probably need to see the dermatologist. And people who are at risk, a little bit older, a lot of sun exposure, lighter colored skin, we're going to offer them an annual skin exam by the dermatologist or the derm PA. So we'll kind of hone it in. Like let's say you're treating a leg with veins and you're pulling a stocking up and you recognize something that you've been trained looks abnormal. You say, you need to get that looked at. Let me set you up with an appointment versus just sliding the stocking over, right? So nobody should have a missed skin cancer that's rolled through our doors, at least not voluntarily. And we have the dermatology screening sheet, and then we use these. We kind of stopped. I think what happens with dermatologists and the PAs maybe got a little resistant to seeing the patients, so we're going to kind of work with them. But it's dermatology screening. I have been offered a skin cancer screening with Allure Dermatology today. Yes, I would like to have a skin cancer screening. No, I decline, or I'd refer it on a different date, which might be the case when we don't have a dermatologist here, or a dermatology PA. Name and date, and we'll keep the copy of this. We do bill it their insurance. And some patients might decide, I don't really care if I have skin cancer, or it might be a patient that's not appropriate because of age, and the derm PAs will discuss that with you, who to kind of screen for. But the reality is that we shouldn't be picking up skin cancers when they need more extensive surgery. We should pick them up earlier. Okay, vein screening. Obviously we know we do, a lot of veins, we do it better than anybody else. And a lot of people figure they got to just live with this. So you might be here for dermatology or hormones or cosmetic or surgery, Botox, and not realize that, this leg pain, leg discomfort you have can be treated. And we know that 40% of adults, 40%, okay, almost 1 out of 2, have venous insufficiency, which is the cause of varicose veins. So if we know almost half the people have venous insufficiency, and today between our 4 offices, or 3 offices that are open today, we have about 400 patients. That means 200 of them have venous insufficiency, and probably 100 of them are here for venous, and so that cuts it down. Maybe another 100 patients are coming through for cosmetic and different consults, and they don't know that we offer vein screening. And you just use the standard vein screening sheet. If they have the symptoms, set them up for an ultrasound. So those are 2 that are kind of our workhorse treatments that we've been talking about. We're doing pretty good with. I know dermatology is very good at screening people for venous insufficiency. We got to do vice versa. We got to screen all our patients for venous insufficiency. We're going to go through and make sure we've checked everybody, at least acknowledge any leg symptoms that you're concerned about venous insufficiency or varicose veins, then screen them. Just have them put some shorts on. Dermatology, set them to see the dermatologist. Then there's 2 other things, which is hormone replacement. Now, the hormone replacement thing, I've talked about this in different videos, so I'm not going to go back in that entirely. But suffice it to say that if women go on actual hormones, we would call bioidentical hormones, and they stay on them for a long period of time, preferentially the rest of their life, we know that they will cut the risk of fatal heart attacks, women, by over 70%. Okay, study done in the Netherlands, followed people for 16 years, and they found over 70% reduction in death rate from heart attacks. I mean, that's pretty good reason to go on hormone replacement. And some women are worried about hormone replacement because they heard they cause breast cancer. Well, hormones do not cause breast cancer, okay? Drugs do. So the drugs used to replace hormones do. And we know that studies show that if women go on hormone replacement therapy, particularly the type that we offer, which includes testosterone, kind of the master hormone for women, the risk of breast cancer drops by over 50% and long term by over 70%. So should we be screening women for menopause? You know, they don't know this is an option. A lot of them hear from their doctor, well, you don't want to go on that because you got to stay on it long term, or, you know, these drugs cause cancer, your insurance covers the drugs, that's all we can give you. They have options, you know, they can pay for the hormones and drop the risk of breast cancer and heart disease by over 70%. Okay, very profound. So when women are coming in here, we have a sheet. I don't really, not crazy about this one. It's a little too wordy. I'm going to redo it, but this one we have for right now. It's like the brochure we have for Conquer Menopause, and it tells them about like the newest information. I have the references here from the scientific articles, so you can take it to the doctor. And on the back here, there's a prescription, so you can have the, you know, if they're screened and it looks like somebody we're going to potentially treat, I have the provider sign the prescription, circle one of these codes: hormone imbalance, hypogonadism, fatigue. I think that's actually the male one. We got to fix that, Mary. So we put the male, you know, diagnosed on the female sheet. So we'll fix that. But anyway, circle the hormone balance, put their name on it, and have it initialed. And this tears right off. You just fold it and tear it right off, the little perforated thing. So there should be no woman that comes to our office that did not know that they had an option for men. Okay. The men one is kind of like a little newer than women in terms of that overwhelming evidence. So the women, we've known for the past like 8 years or 10 years that we should put women on bioidentical hormones and, you know, of course, testosterone, estrogen, progesterone, or at least testosterone, to reduce the risk of cancer and disease and death. Because part of that, the drugs are shown to be sort of defective. For men, we've known for years that men should go on hormone replacement if their testosterone is low, but really the focus has been on low testosterone for problems with sexual function. But studies have shown overwhelmingly that the risk of diabetes, metabolic syndrome, which is a precursor to diabetes, obesity, and death go up when you have low testosterone. In fact, in the international consensus, they stated that not treating low testosterone because it's part of normal aging would be as absurd as not treating hypertension or diabetes or heart disease, because it's something that happens as you get older. It's like ridiculous. Anyways, on this one here, there's a questionnaire in the front. This is called the ADAM questionnaire. And they answer these questions. There's a little key down here to tell them whether or not they have low testosterone. Pretty accurate. And on the inside, it talks about the key bullet points from the international consensus explaining why we should be screening all men for low testosterone that are, say, over 40. And it's not certainly an age thing. For women in menopause, we can guess in their late 40s, early 50s. For men, about the same age, but a young man that has low testosterone symptoms, we might not be screening him for it. But certainly men in their 40s and 50s, we should. Guy younger has it, they're going to seek out treatment because they know there's something wrong. But men in general that are middle aged, they don't know there's an option. So same thing here, we're going to do some blood work on them, circle the code, and then have the provider sign it, and we'll get their blood work and send them up to see Michelle in 2 weeks. That's how long it takes for the blood work all to come back. And really the lowest resistance, particularly with men, is just go ahead and do it now. If you give them the prescription to take home, they're going to stick in their car with a bunch of other junk, and life goes on, and we miss an opportunity to intervene on their chance of developing diabetes, heart disease, obesity, heart attacks, and death. Okay, so all-cause mortality, meaning chance of dying, are lower when you go on hormone replacement. Chance of prostate cancer goes down when you're on hormone replacement. The chance of breast cancer in women goes down when they're on hormone replacement. So it's something we need to address. So if we're really good at it, we shouldn't be focusing on offering every possible service to everybody in our community, but every service that we are experts at in our own community of our office that we're doing, that we can handle high volumes of, we should be letting all our patients know about it, especially when it has this much impact on their life. So that's the plan. We're going to get back in the rhythm of screening patients. There'll be some questions about, you know, what about insurance and how much time we're setting for it and what hours we're screening. That's something that you guys got to work out on your own. I'm not sure I haven't answered those questions. You know, my follow-through is like a 2, so I didn't work all those problems out. But the vision is that a patient coming through our office has an option going hormone replacement. They're in menopause or in andropause for men. They should not be missed with venous insufficiency, and they should not have a missed skin cancer. Okay, so that's the mission, that's our vision, and you got to figure out how to carry this out. We made some tools for you, and it's your individual office. You got to figure out how you're going to handle that. But this is something we need to do for all our patients to better their lives. Thank you very much.